Welcome back to the Osteopathic Manipulative Medicine Board Review Series for Doctors in Training. I think from now on we'll just say OMM or OMT. What a mouthful. This lecture will cover Chapter 2, the cervical spine. We'll start with some anatomy, talk about the motions and somatic dysfunctions, and then we'll finish up with some clinical cases. And of course, we'll answer the questions at the end. First, let's start with the anatomy. The cervical spine consists of 7 vertebral segments. We should also take the neighboring occiput and T1 into account when evaluating cervical mechanics. While C1, the atlas, has the largest transverse process of all the cervical vertebra, it does not have a body or a spinous process, so it is considered to be atypical, as well as C2. C1 articulates with both the occiput on top as well as C2 on the bottom. C2, also called the axis, essentially picks up the body of C1, which becomes the dens. The dens articulates with C1 and allows rotational motion. This is the AA, or atlas axis joint, which is responsible for 45 degrees of rotational motion in either direction. C3 through C7 are very similar. They each have small transverse processes and bifold spinous process, as well as a transverse foramen through which the vertebral artery passes on its way to the brain. Each vertebra has superior and inferior articular facets. Remember the superior cervical facets are facing which way? Backwards, upwards, and what? Medial. C7 actually has the most prominent spinous process in adults. But you already knew that because it's the vertebral prominence that you use as a landmark when palpating cervical spine. Also, C7 typically does not have a foramen in its transverse processes for the vertebral artery. Now, there are some palpable landmarks in the cervical spine that you definitely need to know. The transverse process of C1 is palpable between the angle of the mandible and the mastoid process. C2, the highest possible spinous process of the cervical spine. And C2 through C7 have the articular pillars. These are super helpful in finding somatic dysfunction in the neck. Have you heard the term string of pearls? That's what my professors used to always call the articular pillars. Look for the string of pearls, they'd say. What the devil are they talking about, I'd say. So naive then. The articular pillars are the portions of the bone between the superior facet and the inferior facet. Because of their relationship to the facet joint, fullness or tenderness around the pillar is a pretty good sign that there's something amiss. There are a few key muscles to really know for the cervicals. First, the scalenes. They're anterior, middle, and posterior scalenes that originate on the transverse process of C2 through C7 and insert on the first 2 ribs. Anterior and middle scalenes insert on the first rib, and posterior inserts on rib 2. A great way to remember this is saying, I get up at 1 a.m., 1, first rib, a.m., anterior middle, 2p, second rib, posterior. I get up at 1 a.m., 2p. Now, the scalenes are also important because of the relationship with the brachial plexus. The brachial plexus travels between the anterior middle and the posterior scalene on its way to the upper extremity. Remember thoracic outlet syndrome? It turns out that tight scalenes can actually compress the brachial plexus and give you neurologic symptoms in the ipsilateral arm. The sternocleidomastoid, or the SCM as we call it, originates on the sacrum and middle 1/3 of the clavicle and inserts on the mastoid process. When activated, the SCM causes side bending toward the ipsilateral side and rotation away. You can see how shortening the distance between the origin and insertion would cause side bending towards and rotation away. In fact, this is the counterstrain position for the SCM. You might use this technique for torticollis, a clinical condition where one SCM is in spasm. Remember that the SCM is innervated by cranial nerve 11, the accessory nerve, part of your neurological exam. The suboccipital muscles, known as rectus capitis posterior major, rectus capitis posterior minor, obliquus capitis inferior, and obliquus capitis superior, or we'll lovingly call them the suboccipital muscles because who really has time to say all of that? These are the small muscles connecting the occiput C1 and C2. Don't worry about the exact origin or insertion of each. Just know that they all insert at the superior nuchal line and are involved in OA movement. Hypertonicity of these muscles are associated with headache, especially tension type. Raise your hands for anyone who's had at least one while studying for this exam. That's what I thought. Remember suboccipital release? These are the muscles we are targeting with that technique. Grab a partner and practice it. You'll thank me later. Lastly, trapezius and levator scapulae. These large muscles are often involved when the chief complaint is neck pain. The trapezia extends from the external occipital protuberance, or the inion, and supranuchal line of the occiput down the spinous process of the thoracic vertebra and inserts on the acromion, spine of the scapula, and lateral 1/3 of the clavicle. The levator scapula originates on the transverse process of C1 through C4 and inserts on the superior angle of the scapula. While the levator scapula is mainly involved in scapular motion, contraction of the levator scapula will cause side bending of the cervical spine to the ipsilateral side if the scapula is fixed. Next, we need to talk about some ligaments. The alar and transverse ligaments hold the dents in place. The laxity of these ligaments are associated with rheumatoid arthritis, Down syndrome, and other connective tissue diseases. So you want to be careful, and you obviously want to ask about these conditions before you do any work in this area. You could have subluxation, and that could be deadly. Next is the ligament of Nuchae. This extends from the superior nuchal line down the spinous process of the cervical spine. The ligament of flavum continues from C2 all the way down the sacrum. The posterior longitudinal ligament also runs from the posterior aspect of the vertebral bodies from C2 down to the sacrum. It prevents posterior and posterior lateral disc herniation. This ligament gets narrower as you go down the spine, which explains the reason why you get the majority of disc herniations in the lumbar spine. Next is the anterior longitudinal ligament, which runs along the anterior surface of the cervical spine down to the sacrum. This is often injured in whiplash injuries and prevents anterior displacement of the cervical vertebra on each other. Now let's talk about some joints. First being the occipito-atlantal joint, with the occiput resting on the atlas. There are two horizontal convex condyles that rest on the atlas. Next, you have the AA joint, or the atlantoaxial joint. It has 3 points of contact, but there's no disc. You have the two facets, and then you also have the dens that articulates. And the motion here, mostly rotation of the AA joint. Next, we have C2 through C7. These vertebrae articulate with the ones below. They have a superior and an inferior facet and a disc between the vertebral bodies. C3 through C7 have joints of Luschka, or the uncinate processes. These are superior projections on the lateral aspect of the vertebral body. They protect the nerve root by limiting lateral disc herniation. The cervical nerve root exits above the corresponding vertebral joint. C1 nerve root actually exits above C1, and C8 actually exits below C7 vertebra. But wait, is there a C8 cervical vertebra? Why, no, there isn't. Remember this fact when we review the location of the nerve roots for the remainder of the spine. The nerves exit the spinal canal between the pedicles and are shielded by the transverse processes. C1, C2, and C3 contribute to the cervical physis, with C3, 4, and 5 contributing to the phrenic nerve and the function of the abdominal diaphragm. C5 through T1 contribute to the brachial plexus. The superior, middle, and inferior sympathetic chain ganglion lie anterior to the cervical vertebra. We'll talk more about testing of the cervical nerves in the upper extremity lecture later. Okay, now for cervical spine motion. Flexion and extension is the primary motion of the occipital-atlantal joint, but also moves in combination of side bending and rotation. The OA is always side bent one way and rotated in the other. It's important to note that this has nothing to do with Fryet's laws. Remember, Fryet's first and second laws do not apply to the cervical spine. The occiput moves across the atlas in a coupled gliding motion due to the shape of the condyles. So looking at the models that we have here, here is a small version. This is the occiput and the spinous processes. So now we're going to look at the larger version. So occiput, back of the occiput, spinous process. We're going to look at just the OA joint. So you can see the shape of the condyles here, converging anteriorly, which will add to that side bending rotation motion. Here is the inside of the condyles with the saddle shape. So as the condyles sit
On the atlas, you can side bend over to one condyle and rotate the opposite direction. Do you see it? We'll do it one more time. Side bending to, say, the right, rotating left.
Now you can imagine the occiput gliding across the surface of the condyle. You can see how rotation in one direction causes side bending in the other direction. It isn't just a rule, it's an anatomical requirement of this joint. Being able to imagine this motion of the OA joint will also help you understand the treatment setup for different OA somatic dysfunctions. Also, the OA is particularly important due to its influence on the vagus. In fact, research shows that treating OA dysfunctions in newborns with feeding problems due to poor suckling reflex can improve feeding in these kids. See, OMM even has a place in pediatrics. Next is the motion of C2 through C7. These are able to move in flexion and extension, as well as side bending and rotation. Remember, for the cervicals, side bending and rotation will always be in the same direction. Again, it isn't one of Fryet's laws, but as a result of the facet orientation. This is useful on boards because you might be given the diagnosis question that only tells you rotation or side bending, and you have to infer what the other component is. Also, when you are diagnosing the cervicals, don't forget to address the sagittal component as well. These dysfunctions can be flexed, extended, or even neutral. C2 through C7 account for 50% of cervical rotation, as well as about 50% of flexion and extension. But they also account for nearly 100% of side bending component of the cervical spine. Speaking of diagnosis, let's discuss somatic dysfunction of the cervical spine. And the crowd goes wild. Now, you have two ways to diagnose the OA. You can use motion testing or static landmarks. Quick! If you're using static landmarks, what TART finding are you assessing? Asymmetry, of course. And motion testing? That's restriction. Of course, everyone has their own method of motion testing, but typically with the OA, it involves using a translational force that induces both side bending and rotation. Because of its coupled motion, if you translate to the right, therefore side bending to the left, the OA will automatically rotate to the right as well. You can also test flexion extension by asking your patient to tuck her chin and then have them look up, creating a motion at the OA joint. To test the motion of the AA, you want to flex the neck up about 45 degrees and then test for rotation. Why are we flexing up to 45 degrees? To lock out the lower cervicals. Here we're using Fryet's third law. We're using motion in one plane to restrict motion in the other planes. So again, flex the neck up to 45 degrees and rotate the head to each side to see which will rotate more. If you ever find that you are struggling with diagnosis of the cervical spine, just do a quick suboccipital release to relax the muscles and get your bearings. I do this. Then I use what I feel to guide the way I interpret my motion testing findings. The patient likes it too. Everybody wins. Let's move down to C2 through C7. Most of the time you will pick either side bending or rotation to diagnose the cervicals. Me, I like side bending because I usually choose to do HVLA with a side bending emphasis, so when I diagnose, I'm already set up for treatment. But more on that later. If you pick side bending, you will use a translational force to apply the lateral aspects of the articular pillars, i.e. you want to find the pearl and push it to the side. If you push towards the left, this is a left translation which induces right side bending, and a right translation induces left side bending. Remember, motion in the cervical spine is coupled, so right side bending means right rotation. Realistically, you could make the diagnosis just by testing side bending or rotation and then flexion or extension. So let's practice some double negatives here. If you find, are you writing this down? If you find that C4 is restricted in the left translation, which way is it rotated? Tick, 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 ding. What do you think, left or right? So left translation means right side bending, but it's restricted there. So it's side bent left, and side bending left means rotated left. So there's your answer, rotated to the left. But what if you aren't a side bending junkie like me and you like your diagnosis to be more well-rounded? To test your rotation, you will also palpate along the pillars, but your force will be applied in a more applied to the posterior aspect of the pillars in an anterior direction on one side and then the other side. And don't forget your sagittal component as well. Add a bit of flexion or extension to the segment you're testing. If rotation or side bending improve inflection, i.e. it gets easier to rotate or side bend, the segment is flexed. If it improves in extension, then it is extended. If there's not much change in either flexion or extension, it's probably neutral. It's as simple as that. Okay, now we've gone over diagnosis of somatic dysfunction. Now let's talk about what to do about it. Of course, we will cover individual treatment methods ad nauseum, so let's not go there yet. But it's important to note that when you approach a patient with neck pain, you need to look past the cervical spine and to the related structures. Of course, the old saying, treat what you find, holds true in any situation. So make sure you find the source, but also look to the upper cervicals and the ribs, especially rib 1. Look as far away as the shoulder and even consider the diaphragm. Remember the whole body is a unit tenet? Suboccipital and paravertebral muscle spasms are usually associated with the upper thoracic or rib dysfunction on the same side. So treat those areas first, and when you finally treat the cervicals, it'll be much easier. Likewise, consider looking to the neck as a source of pain in other regions, especially the arm. Arm pain is frequently caused by dysfunction of the cervical spine. Sperling's test is a compression test that will recreate a patient's radiating pain down the arm in the cases of foraminal stenosis. If the test is only locally painful in the neck, but does not radiate, then in fact facet arthropathy is more likely. Finally, if the pain is felt on the opposite side of the same level, then muscle spasm or strain on the contralateral side is more likely the culprit. The distraction test is the exact opposite of the Sperling's and will alleviate radiating pain from foraminal stenosis. Other cervical spine tests are Wallenberg and Underberg's tests, but these help test for vertebral insufficiency, which is a big contraindication for cervical HVLA. That transitions well into our next and final topic for this video, clinical conditions of the cervical spine. First, foraminal stenosis. Now, foraminal stenosis is pathological narrowing of the intervertebral foramen that can be caused by a number of processes. Hypertrophic degenerative changes within the joints of Luschka or facets, or osteophyte formation associated with arthritis can cause stenosis. Often these changes or osteophytes can be visualized on X-ray using an oblique view. While OMM cannot reverse degenerative changes or treat osteophytes, paravertebral spasm can worsen or even precipitate symptoms, making it amenable to OMT, which can increase range of motion and help maintain existing function. Foraminal stenosis is characterized by pain that shoots down the arm, so that'll be your first clue. Your second clue will be a positive Sperling's test. Now, when is the Sperling's test considered positive for foraminal stenosis? Is it when pain is elicited in the neck? No. It's positive foraminal stenosis when the patient's radiating pain is reproduced. If the pain is just in their neck without radiating down the arm, then it may be facet arthropathy. Whiplash is also pretty common and something you will probably be asked to treat in the future. We all think of whiplash in the context of car accidents, but it can really be any sort of sudden impact from behind causing strain on the cervical muscles and ligaments. Which ligament in particular? The anterior longitudinal ligament. Like any acute injury, initial treatment should be indirect with multiple follow-up sessions. Well, will you look at that? It's already time for questions. Pause the video, answer the questions, except for number 4. Go ahead and just skip that one and hurry back. Okay, question 1. Which of the following muscles helps elevate the second rib with forced inhalation? The answer is C. And how did you know that? Because we get up at 1 a.m. to pee. Question 2. Stenosis of the intervertebral foramen between C3 and C4 may affect which nerve root? The answer is C. The C4 nerve root, because in the cervical spine, the nerve root exit above the corresponding vertebra. For me, this is just one less thing to memorize because I just think about this. There is no C8 vertebra, and the C8 nerve root exits below C7 vertebra. So, cervical nerve roots exit above their vertebra except for C8. C8 causes the change, and now all spinal nerve roots below C7 will exit below their corresponding vertebra. Helpful? Don't worry, this will get reviewed again in the thoracic and lumbar chapters. I have faith that you'll get it. Question 3. The primary motion of the occiput on the atlas is, well, the OA is responsible for 50% of which motion in the cervical spine? Flexion and extension. So the answer is A. Sure, the OA also rotates and side bends, but those are relatively minor in comparison. Question 4. In the evaluation of a patient with suboccipital pain, you find that his atlantoaxial joint is restricted in the right rotation. Which of the following statements is true concerning the symmactus function? Okay, I asked you to skip this one because it's a shady question. As far as you're concerned, the AA only rotates. It even says that on page 15. I mean, really. And even if there was side bending to worry about, the cervicals are always side bent to the same side as rotation. So A wouldn't be the answer anyway. So let's just throw the whole thing out. Question 5. Which one of the following statements concerning the cervical spine is true? Why, the answer is D, of course. And you knew that because you know that translation in one direction really means side bending to the other. Question 6. All the following statements concerning the articular pillars are true except they are used by osteopathic physicians to evaluate cervical motion. That's true. It is the portion of the bone located between the superior and inferior facets. That's also true. They are located anterior to the cervical transverse processes. Not so much. But let's look at the last one just to make sure. They are also referred to as the lateral masses. That's also true. So our answer is C. They are not located anterior to the cervical processes. They're actually posterior. Question 7. Which cervical segment is best evaluated by flexing the neck to 45 degrees and rotating the head? I bet you went looking for the AA and were baffled when you didn't find it. So is it C1 or C2? Well, you always name the motion of one vertebra in relation to the one below. So the answer is B, C1. Well, that wasn't such a pain in the neck. But seriously, while we're on a roll, let's move on to the thoracic and rib cage in video 3.